Well, hello everyone, and welcome to the third session of Virtually Casper. This session is entitled Great Adaptations, COVID-19 Inspired Vision for the Future of Healthcare in Canada. I want to begin by acknowledging that we are on Indigenous lands. I invite you to reflect on how we can show our respect for the treaties that were made on these territories, acknowledge the harms and mistakes of the past, recognize the ongoing present-day colonial violence that is faced by Indigenous peoples within healthcare, education, justice, child welfare, and government systems, and to join me in dedicating ourselves to moving forward in partnership in the spirit of reconciliation and collaboration. We are thrilled to confirm that the entire series of sessions for Virtually Casper is sold out, and we welcome all of you to today's session. Virtually Casper is a new initiative that will continue in the future with our exciting remote sessions throughout the year to further complement the annual conference. If you're not already a member of Casper, we encourage you to join or renew your membership, as there will be future remote events and activities that will be exclusive to Casper members only. We would like to thank our sponsors for this session. The Canadian Institute for Health Information, CIHI, is committed to collecting, analyzing, and sharing credible health data to help improve our healthcare system and the health of Canadians. CIHI has compiled their key reports and resources containing information related to the coronavirus pandemic on their COVID-19 resource webpage, which we encourage you to bookmark and share. So, what are we going to be doing today? Let me just say that we have a very exciting panel for this session. We encourage you to write your questions using the Q&A option at the bottom of the screen during the session. We will monitor those questions and do our best to ask as many as possible during the Q&A session. The chat feature will be disabled while the panelists are presenting, and we encourage you to use the Q&A just for questions rather than chatting with other participants. The chat will be live during the Q&A period, which would allow you to communicate with other participants. We ask all participants to observe respectful communication in both the Q&A and chat features during the session. Please note that all sessions will be recorded. So I am very pleased to introduce our panelists for today's session. Our first speaker will be Vivek Goel, who is Vice President, Research and Innovation and Strategic Initiatives at the University of Toronto. Vivek will be followed by Zaina Kayat, who is a future strategist with SE Health. What a challenging task. And our third speaker is Joshua Tepper, the President and CEO of North York General Hospital. I'm pleased to invite Vivek to be our first speaker now.
Thank you, Alan, for the introduction, and thank you everyone for joining us today. I'm just going to share my screen here and get the presentation started. So I'm going to be talking about a population health perspective, and I've been asked to just take a quick overview of where we're at in the pandemic. And then in terms of looking to the future, I'm going to talk a little bit about what the next few months and years could potentially look like. And then close with a few words and thoughts about how I hope population health and public health will be treated following this major event, and that all the money doesn't just keep going back to Joshua's and Zaina's sectors. But that could be a conversation for discussion afterwards. So first of all, I just want to take us back to the beginning of March, which really was when here in Canada, we got into the very restrictive public health measures that we're now facing. And I just quickly remind everyone that from a pandemic management perspective, there are a number of phases from preparedness, which we should always be in. And again, there'll be conversations to come about how prepared we were. Containment, the early stages when we have a new emerging infectious disease, and we try to contain it, and then mitigation, which is what we're in right now. So containment is we keep it from spreading further. We identify the cases as soon as they occur and do the contact tracing and keep it from spreading. China moved through that phase relatively quickly. We were actually doing quite well in Canada up until the end of February. We actually had failures of containment largely in places like Italy and the United States and New York State, and it's those cases that actually came in late February, early March, that resulted in the situation we're facing. And I'm sure many of you remember these graphics in the media quite a bit in late February, early March. And what this is really showing is with the new infectious diseases for which there's no population immunity, such as we have for the SARS-CoV-2 virus, that the healthcare system capacity gets overwhelmed without protective measures. And the protective measures, if we had a vaccine or antivirals, could be pharmaceutical, or as we don't have those, they're non-pharmaceutical public health measures, such as the restrictions that we've put in place. What's important to remember is the goal of those measures is to delay this peak so that the healthcare system doesn't get overwhelmed like we saw in Italy and New York City. The area under the curve, which represents the number of cases, doesn't actually change that much. Unfortunately, I'll come back to this, I think we've set people up to think that we've done all of this to get rid of COVID-19. And we're not going to get rid of COVID-19. We did this to keep the healthcare system from being overwhelmed, and quite honestly, we did it to keep those who were most at risk from getting the disease. And again, we'll come back to this. We failed miserably in our long-term care facilities. So where do we go? So that previous graphic shows some nice, smooth hypothetical curves. The reality is there's probably a number of different scenarios. One is that we have recurrent peaks, and if the healthcare system line is here, we may have to put restraint measures in again as we start to see the healthcare system getting to capacity. So the other one, and the one that I think is of most concern, is a second wave that may be larger than the first wave. And so if this was healthcare capacity, that this would come in the fall at the same time as other respiratory illnesses, and in particular really overwhelm us. And third is the slow burn scenario. That is that we maintain the cases below the healthcare system capacity. And that likely, I would say, is what we're into. And I think if we manage our public health measures well, we might be able to maintain for some time to come. One thing I want to say a word about is, will a vaccine save us? A lot of darts being thrown at the board right now. There's well over 100 candidates, and every week there's another report of a vaccine candidate entering clinical trials. I hope as much as anyone that we will get a vaccine quickly. But we also have to be prepared for the fact that a vaccine may not get developed and approved in the 18 months to 2 years that some optimistic people are thinking of. Donald Trump says he'll have one by December. And even if we do get a vaccine, it may not be perfectly effective. It may have limitations. We may have to do multiple doses. And then if we do get a vaccine, the harder challenge is going to be actually rolling out a global immunization program. And there's all the concerns about the manufacturing of the vaccine. But in order to run a global campaign, there's lots of other supply chain challenges. And if we thought getting PPE and respirators was a challenge, think about the needles and syringes and swabs and information systems that are going to be needed, as well as the trained personnel to run that global campaign. So I simply say that because while a vaccine holds great promise, it will take time, there are risks, and so we have to be prepared for that slow burn or one of the other scenarios, for some time to come. And that has to inform our thinking about our future of the healthcare system. A couple of words about the outbreak itself. These are current numbers nationally. The one thing I just emphasize here is 60% of cases or more under the age of 60. If we look at the deaths, about 5% under the age of 60. And as Alan referred to, and I'm sure we'll talk about further, the vast majority of these deaths, unfortunately, have been for residents in long-term care facilities. And so the key message is that there are really two different outbreaks in this country. What's happening in our long-term care facilities and in certain other congregate living settings like homeless shelters, and what's happening in the rest of the broad community. There are cases, but very much smaller proportions of those cases are getting hospitalized, put on ventilators, and dying. And so again, I take us back to why we did the public health measures. We did it to protect those who are at highest risks, not to protect the entire population. And again, I'm not going to go through who's at highest risk. We know this information. I think as I turn now to the population health aspects of this, I think what COVID-19 reminds us of is who gets a lot of different types of illnesses. And it doesn't really matter what condition we look at, whether it's infectious disease or chronic diseases. We know that there's certain populations that inevitably get more disease, and they tend to come from lower income areas. They tend to be immigrants. They tend to be working in lower paid settings. They're the people that are keeping our society running while most of us are able to comfortably continue to work from home. And they're the ones that are getting exposed to COVID-19, and then they take it home to their families, often in settings where they're not able to self-isolate. And the latest data released yesterday by Toronto Public Health demonstrates which neighborhoods, for example, in Toronto, are most exposed to COVID-19. So again, I just use this to remind ourselves that the population health social determinants that we've known about for decades. We're coming up to the 50th anniversary of the Lalonde report. Think about that. And we still haven't really grappled with how we structure our health systems so they're actually hitting on all of the determinants of health and not just focusing in on one. And the one that we tend our time to focus on determines about 10% of overall health outcomes. And all these other determinants are contributing to health as well. Social circumstances, individual behaviors. We know that diet, physical activity, alcohol consumption are the strongest predictors that probably account for most of this 40% over here. We also know that many of those predictors are actually interrelated with the social economic determinants as well. But we tend to focus most of our research on the human biology side of other things, and most of our investments on the healthcare system side of things. And if we really want to think about improving the health of the population, we have to go back to what we've known about for well over 5 decades now. So I want to say a few words about something that we've not been talking about a lot as a society. So we've engaged in these public health measures. We're coming up to 3 months. And even with the phased reopening plans that are being talked about, the last stage in Ontario, and it's the same across the country, will still maintain pretty stringent restrictions. For example, 2-meter separation. That is going to make it very difficult for many businesses, museums, universities such as mine, to actually function. And so that's going to continue to have very significant impact on our society, on our economy. And we need to think about what the broader impacts of our public health measures have been. And I've listed a number here. The delayed medical visits, surgical procedures. We've got a number of studies now coming out on, for example, with cancer in the UK. They're estimating on the order of, I think, between 10 and 15,000 cancer deaths over the next couple of years as a result of both the people who are not getting treatments while procedures are shut down, but also the people that are now not being diagnosed because they're not getting access to the X-rays or CT scans or MRIs or other things. And we know that whenever things do start to come back, it's going to take a long time to catch up on all of those things. Delayed immunization programs, there's unbelievable estimates coming out of Africa around the childhood diseases that will start to resurge as a result of this. Domestic violence, child abuse, lots of reports on this. And unfortunately, one of the things that has been seen is while kids' helpline calls have gone up, reported cases of child abuse are actually down. That's because everyone's still at home. And so when the partner who might be able to take the child out can't leave now because the abusive partner is still at home. Mental health effects of isolation. I know Joshua's been writing about this. Delayed early childhood development. We know that early childhood development, particularly for preschool kids, is one of the strongest predictors of lifelong health and social outcomes. And continuing to keep kids out of daycare and schools will affect that. It also affects the parents, as we know. As I mentioned, physical activity, food insecurity, increased alcohol consumption. 40% of lifelong health outcomes are driven by things that are likely being driven up as a result of prolonged shutdowns. I do note there's some things that we might be better off. Air pollution levels are down. There's fewer motor vehicle accidents, but interestingly, there's still, per accident, there's more fatalities because people are driving faster. And then the final thing, which we're starting to do some modeling on, is that we know that unemployment leads to increased mortality, and from the meta-analysis, relative risk of 1.7. So with the vast numbers of people being unemployed, we are going to be facing with increased health consequences from that. So I just want to emphasize that while the debate, particularly south of the border, has been polarized as one of health versus the economy, this is really a health debate that we have to happen about how do we balance our public health measures. So this just graphic is showing another set of waves that we might face over the coming months and years as a result of all of the public health measures, in addition to the waves of COVID-19 disease that we will face. And so I think we need to be weighing these against each other. So how do we get out of this? I think we have to move away from this thinking that we're going to eradicate COVID-19. And that's unfortunately what a lot of our political leaders right now are communicating, is it's about eliminating every case of COVID-19. We have to learn to live with COVID-19 in a smart way and start scaring people. It's okay to go to Trinity Bellwoods Park in Toronto. Be safe about it. We got to protect those at highest risk. We've not done a great job of that. We have to get smarter about that. I'm not going to get into testing and contact tracing. Lots of people talking about it. We have to get our act together, and we have to be ready for the sporadic cases that will inevitably come as we open up the economies. And we have to support all sectors of society in reopening in a functional way. And we have to really look at the evidence base around that 2-meter separation. Because if we maintain the 2-meter separation for several years, we're going to crater our economy and we're going to crater the future of our health. And while there's a lot of work on vaccines for immunity and herd immunity, we actually have to think about legal immunity. Because as long as we're saying that every case of COVID-19 is an adverse event It's an occupational health issue. Employers aren't going to be able to bring people back. Stores aren't going to be able to safely operate. Loblaws is getting sued for an outbreak that people claim took place there. So we have to rethink the model here. We don't sue people when we get flu at a grocery store. But yet we've created an environment where people can get sued over COVID-19. So in my last few minutes, I'm just going to look to the future. And as we come out of this, can we actually properly strengthen population public health services? As with long-term care, we don't need another commission inquiry. We don't need another report. There's dozens of them that have been done over the last decades. And we have the reports after SARS, and we have to go back and we really have to look at the key issues. I've often said that the biggest threat to the health of Canadians is the Constitution Act. We're seeing this play out in spades right now. The division between federal, provincial, territorial services. If we think about rolling out an immunization campaign, Health Canada is going to be responsible for approving a safe vaccine. Public Health Agency Canada has to procure the doses. The provinces and territories deliver it along with local regional health units. We wind up having so many layers of coordination when we do it. Rolling out a program for Canada will be a nightmare. And that's just one thing that we have to be able to do. So we have to think about a new model. I note that the sponsor of this session is CIHI, where I have the privilege of being the vice chair of the board. But I don't think that's why I got onto this panel. But CIHI works in the federal, provincial, territorial space. It works in an effective way with having deputies around the table, having health sector partners, having other partners around the table, and coordinates things in a way that very few organizations do. So I think there's models there of how we could do public health in the FPT space. We have to get real about health information. Again, no shortage of reports about this. The lack of data, the fact that individual researchers and other groups are putting up websites to share health information. I think we should be embarrassed as a country, as a society, that we can't even get our death numbers out. Ontario is still using paper for death certificates. And we have to hold health systems and providers to account for health outcomes and not for outputs. And that remains the predominant way in which we measure the performance of our health system. So I'll just leave you with, this is drawn from the Sustainable Development Goals, the SDGs. And, this really presents a picture of how, if we embrace the model of sustainable development, it will help on so many different arrays. It'll improve our environment, but it'll also improve the health of our population, and we'll be able to get on with things. Thank you very much.
Thank you, Vivek. Perfect timing, and you can take that call now.
That was my timer.
Perfect. Well, you finished right on time.
Yeah.
So lots of very, very interesting things to talk about in the discussion around that. Before we go on to Zaina, I just wanted to remind people that the Q&A is open. You can post a question either to an individual panelist or to the panel as a whole, and we'll see how that goes. I'll be monitoring that and asking those questions during the discussion period at the end. And so now, without further ado, it's over to you, Zaina.
Thank you. I think Vivek's setting up was just perfect. I reflect Vivek, Malcolm Gladwell did, I think, a Walrus Talks or something a few weeks ago, and of all the big ideas he has and everything he sees, he said, what do you think is the one best thing that's going to come out of this? And he said the resurgence and elevation of public health, flat out, and I agree. We've been using this word silver linings a lot. I heard it even yesterday on some of the sessions. So I'm going to use that to frame a bit of where are things going to going from a future strategist perspective, and that's what I do. I work with a 112-year-old health organization that really wanted to have space to create the future based on the signals we're seeing and not protect the past. So many of you have probably seen my typical future of health talk that frames where healthcare is going. And we talk about this really a paradigm shift of an orientation around optimizing for the system and the payer and the people who work in the system, to a bit of a more bottom-up optimizing around the people who have the biggest stake in the work we do. And that there are like three big forces that come together, like any paradigm shift, to kind of tip you over this big pull from patients and families who have all the information, have power, and really a revolution that Eric Topol characterized in this book, that the business model for 150 years no longer serves. And so when your business model no longer works, either you have to update it or you go out of business. And that's certainly happening in healthcare, as Vivek alluded to, with an output and activity-based model, and supply and demand just completely out of whack. And then that there's technology that we didn't even contemplate would exist when we designed our systems and laws and acts that can actually do something about the first two sources. So that's kind of this perfect storm we were in pre-COVID. And that would result in, some pretty fundamental shifts that really upend and rebase almost everything about what we all do and how we work, including how we research. And first at the top is a shift from reacting and sick care to proactive, predictive, which, really gets you out of the healthcare system completely. Moving from crude and analog. This morning, Vivek, the tweets were about how Public Health Toronto is getting data on infection by fax and email and mail. So much more personalized, much more intelligent. A massive shift from, patients having to go to care. So the modality from institutions to this word that, exists in pretty much every other sector called omni-channel. And that was explored at depth yesterday with Sasha. Duration from episodic and intermittent to much more continuous and team-based. A big shift of power of who makes decisions from the provider to what I call people-powered healthcare. And then finally, a business model shift that's long overdue of, us as the funders of the health system paying for the results and not for the activities. So we were on a slow burn to that and lots of barriers, and I always talked about that. I would say, with COVID, those forces that were both pushing us out of the old because they made no sense and pulling us to the future have now been really amplified. On patients and families, like overnight, we've all had a shift in our behaviors and our patterns, and a big driver is this risk of personal contact that I know was explored yesterday. In terms of the supply-demand imbalance, like overnight, demand for equipment and staff and new policies that don't make sense when you're trying to deal with a crisis. So that, was out of whack. And then, demand from technology, whereas before technology to modernize healthcare was pushing itself on the system and we weren't ready. Now, we're in demand, not only just how we deliver services, which everybody's talking about, but how we work. I mean, if you think about healthcare, it's not just the delivery. There's a huge education component and training component and research component. And all three of those are very, very dependent on physical things and physical artifacts. And so those are in demand overnight. And then, of course, the tools and equipment and medicines and, testing, et cetera. So all of it comes together. And so if I do a little bit of a scorecard of, did it really accelerate in Canada, these shifts that were happening anyway? I think if you unpack it this way, the answer is a little bit. So, here's my audit from what I see, and this is a bit of a weighted average across everything in Canada, I think for sure, some things have moved faster around, using data to predict and plan, around moving into other channels. We heard a lot about that yesterday, and a bit more talking and communication because everybody's aligned on getting one job done instead of protecting their own interests. Sadly, I think we haven't moved the mark at all on, what Vivek talked about, which is the bottom one. Nothing's really being done because we're paying for a result. It's still activity-based, and we haven't gotten precise. I think the worst shame of this is we actually, unlike other countries, moved backwards on engaging people and their families as meaningful, important, vital partners in finding solutions and delivering them, and particularly in our long-term care homes, and that's been talked about. I kind of lead a group that's looking at the future so we can plan now, and so we're collecting data and signals from every country. And, you know, if I do kind of my weighted average of what's going on in other countries, I think a lot have moved a little bit further with, you know, pockets of excellence. So in our work, I'm going to go deeper on what does this mean for care of the elderly, because that's what we work on predominantly, and my team, my futures team. So pre-COVID, we had just launched in February a book that culminates a year of research and discovery about what is happening with aging around the world and its implications on every aspect of what it means to age. Healthcare is in there, but it's not the only thing. Where we live, how we spend money, how we save, our legacy, the identity of aging, etc. And so we've been using this book to inform our work as an organization to reinvent ourselves, to, you know, be mission focused on creating the lives that aging adults want in the place they want it. And so we also started to rebrand our whole organization as the home of health. And so it's just fitting that this thing hit, you know, two big things: the elderly population and an obsession with the home as the place everybody has to do everything, and not only in healthcare. So you can imagine we've been very busy, you know, being ready for that. So, you know, the way we're thinking about how to create the future of health is really on, you know, three horizons. So there's things that we and everybody is doing now. And I'd say our lens on that is, sure, we will continue to react, and every day is a new surprise, but we are doing that with an intention that every choice we make now about a better solution or whatever is with a vision of the future we want. We're not just doing it to react for the sake of reacting. And then we've got a set of activities around, okay, what are we planning for in the more near term? So that's kind of the window that Vivek just talked about. And absolutely, you know, we're no longer future proofing, we're now shock proofing. So we're preparing for the next waves we've discussed. If we follow Italy and Spain, the next place is the community and the home. I mean, if you make everybody recover at home and people are in families at home, that's where it's going to spread. And we're seeing signals in Canada already of that, dealing with the delayed care, mental health of our staff, of our clients, and then just completely new behaviors and patterns. And another big piece of the near-term planning is, you know, there's a metaphor my former boss said, you know, it's like we did C-sections all of a sudden to get the baby out of the belly. You know, we can't keep doing C-sections. So we now need to lay the infrastructure to prepare us for the next shocks and for the next normal. That's around talent and the workforce and everything around the health workforce, digital, and of course, equipment. And then finally, we get to, you know, the FAR, which is really redesigning and rebasing for the future. And for us, it's not just my organization. Like, we are part of the health system, and we're trying to rebuild a health system, and we're focused on what's the future health system for the elderly. And I'm going to submit and propose, and maybe Casper can lead us, we ban the word long-term care. Everyone thinks about buildings, and that's not what long-term care is. So maybe it's, you know, elderly care 2.0, and that's what we're working on now. Okay, so that's kind of my thing about the future of healthcare and elderly care. Now I want to kind of go up a higher level of, you know, what can we be thinking about the impact of this on society and on the population, but not from a healthcare lens, but what we as researchers, policymakers, and practitioners can do. So this word silver lining, you know, if you reflect on where it came from, it was an Irish poet in the 1600s who wrote a really, really long poem. It's like 230 pages. So this is one section where he was going through a very, very dark period. And he, you know, he wondered, you know, do I see a silver lining against this dark cloud? And that means that the cloud will go away and the sun is coming. And that's kind of what we're trying to see signals of what can we get out of this and what might happen and where are the new opportunities. Well, where have we seen this before? So, you know, most have remarked that perhaps other than climate change, never in the world has the entire population all been focused very intently on one problem. But these 5 pretty big deals in the history of mankind come pretty close, right? So, the Black Plague in Europe, took out 1/3 of the population, and it is credited for, not only designing beautiful PPE, which you guys can all see up there, but more importantly, at the time, the governance model was serfdom. So the lords and the nobility had serfs who served them, and it was kind of hard to get out of that model. It wasn't really slavery, but kind of close. Well, when this plague decimated a lot of the rural population, a lot of these serfs were the farmers because they prepared the food to give to their noble. And now they were a scarce resource. And the plague is credited with ending that, to shifting power to the front line and ending feudalism and serfdom. World War II, which is, got the word world in it. So the bulk of the world was engaged in that. We haven't had another one since because institutions were created like the World Health Organization, et cetera, to prevent that. But it's credited with quite a few things that changed society. This is a woman greeting her spouse after war, but because all the men were gone, women had to now step up and participate in the workforce, and we didn't go back after that. Some are now saying with COVID, men who are now at home and have to do a lot more than they might have done before, not all men, are now going to have a different orientation to work versus home. The role of government spending, if you follow this, today, government is probably 4 to 10% of most countries' GDP. It's going to get over 40%, and that's what happened because it's needed to drive the economy, and we're seeing that. And then probably the most remarkable is an explosion of product innovation to allow one military to beat the other. And it is said that the Allies wouldn't have won if, all these new products weren't created to help the war. But as you can see, internet and penicillin and aircrafts, we now use in daily life. So that came out of this. 9/11 wasn't a long event. It took 25 seconds, but it is credited with, overnight changing security and transportation policies. You all saw that when you went to fly for the first time afterwards. That's what it's feeling like now in all of our retail centers, community centers, like any physical location. And then what it also did was overnight changed people's attitudes, their perceptions, and their own personal trade-offs around privacy and security for the common good. And I think a lot of that's going to come out of this. SARS, although Canada keeps referencing SARS, what happened in China is a lot closer to what's happening here, kind of at scale. Well, I want to step back. I forgot to mention another big thing that came out of 9/11, you might not know, but the city of New York was decimated. The economy was decimated, everything shut down, and it was the financial capital of the country. And so, the leaders of the 5 boroughs said, let's not just rebuild back to what we were, because we didn't like what we were. We didn't like homelessness. We didn't like the lack of urban structure. So they actually reinvented their city and their economy because they had a chance to start over. China, we can credit SARS for Alibaba, folks. Because people couldn't shop in retail places, their whole attitude about how to consume products and services changed. And that was just when Alibaba and other giants were peaking up, and now they've exploded. So this is kind of the story of Zoom and Shopify right now. And then finally, the financial crisis of 2008 and 2009, because so many people were laid off, that led to, marketplace economy and a bartering of goods that bypassed like a middleman and the whole gig economy and the gig worker. So Uber and TaskRabbit and Airbnb and all that came out of that. And the other thing that came out, you guys might remember the packages that under Harper's leadership for stimulus, policy making like in days that used to take a lot longer. So, you put all that together and apply, that context to healthcare. And, I've given a couple podcasts saying the barriers that we used to have to innovation in healthcare have been smashed. And this is a great quote from a doctor in Bangladesh, that innovations in healthcare right now are the most high demand concept in the world for everybody. Not that we're going to read this slide. I've been keeping a little bit of an inventory of how, decades happened in days. in terms of moving the needle on different things. I highlight in red, a U of T actually like launched a research grant in like 5 days and awarded it for anybody. And I used to help design research competitions where we would have meetings for 2 years, to finally launch the research money. Policy innovation number 8 in hours. Somebody commented the package that the feds put out, that amount of financial policy would have taken 2 years to write in the old way, and they put it out in like 5 days. And then interestingly, and this is where I'm going to end with my point for our researchers, other industries stepped up to be part of this. An explosion of ways that they, one, their businesses were out of business, so they had a choice of retrench and fire everybody, or repurpose our assets and our know-how to both help the problem, but also keep our people employed, and maybe get into a new sector. And so, whether that's making, Canada Goose making gowns or our distilleries making sanitizer, I'm highlighting in red, I've also been astounded by a whole new population of data scientists bringing their tools and expertise and finding meaning better and faster than all of our experts in our academic institutions, and challenging us on how we present data to inform policy making and educate the public. And then I just want to highlight a last one, because this came up a lot yesterday, of these, these digital determinants of health. And, great that you can move online, but not everybody has technology. Well, that's not what I'm seeing. I mean, we were able to overnight get any senior a tablet, Wi-Fi. We can train them and get them literate on tech. And we've been seeing industry, telcos, hardware companies step up. I've been seeing the banks overnight create a dedicated line for seniors, either at the branch or when they call. If you're over a certain age, you get moved to the front of the line. And just everybody stepping up to have preferred access or free things for health workers and educators. And then just this kind of new solidarity, every type of solidarity that, kind of didn't play nicely together. And the one that I think I want to kind of end with is intersectoral solidarity, which is kind of hinted at here. But, if you look at what these major pivotal events were in the world, new economies came out of them. The essential economy is now what we're talking about for what Canada will be next, or the world will be next, where the workers who actually make the world go will become the economy, and not those of us sitting in the office. The whole solution economy, the explosion and the innovation of new ways to innovate, the surveillance economy and the data economy. Of course, the low-touch economy is going to emerge. Every company is reinventing itself for this, or the contactless economy, and then the gig economy. And so unlike these other events where each of those kind of were standalone new ways of the world operating, we have a composite of economies, which I'm calling the pandemic economy. And so what this means is we can no longer be obsessed with using our blood, sweat, tears, and expertise to keep making healthcare spin and try to be better. Every part of society is now linked to healthcare. That was really eloquently captured in this quote by John Singer. Those of us in healthcare, we're here in our bubble, we do our thing, and we've always considered the capital markets that run the economy like over there. And sure, you have a mutual fund and you have a pension, and your universities and foundations invest in the capital markets, but we kept them separate. Singer is saying, these two are inextricably linked right now, and that's never happened in the history of society. And just a couple signals. Bank of Montreal just hired a pretty hotshot Canadian doctor to be their kind of chief medical officer. And I love his quote that, every aspect of their strategy is now being looked at through a medical lens. And I'm seeing this in industry after industry, and the kind of phone calls I'm getting to come help us understand healthcare and medicine, and how to keep our health workforce healthy, our customers healthy, and our supply chain participants healthy. So you'll see quotes from Fast Company that, every company must become a digital health company. True, but every business is now a healthcare business. So what the opportunity I want to end with is they need your expertise of research, of evidence, of clinical knowledge. And sure, you might think, okay, I'm going to lose my top talent to these. And guess what? You are. They're all recruiting them as we speak. But more positively, if we're in the business of making people healthy, that's why we're called to this industry. A vector to the population is our employers who employ thousands and thousands of people, and they need a lot of help to get this right. And I think that's going to open up massive opportunity for new forms of research, partnership, and funding. Thanks.
Thanks, Zaina. That was really interesting. I can just imagine how this conversation is going to go once we hear from Josh. Up to you, Joshua. You're on mute.
So great. Thank you very, very much. Somebody, I think it was Darren Larson, tweeted out, boy, what a great panel. And I was going to tweet back, I hate being the weak link. I should warn you, I don't have any slides, so apologies. And I should also warn Alan that I probably won't take my full 20 minutes, so we'll have to get into the discussion. So my apologies for that as well. But you've been put on notice, so there you go. You know, a couple things. I've been asked to speak about primary care and the hospital care and continue this really important conversation about the future. But, you know, it's hard. We start talking about the future and silver linings, and this isn't a criticism at all. I just want to pause for a minute and say, as exciting as it is to talk about all the amazing things that have happened, I just want to pause for a minute and say that hundreds of thousands of people have died. And as much as we're ready to turn the corner and turn the page and talk about all the awesomeness that lies ahead, a lot of people have died. A lot of people are still sick in our hospitals right now. And there's a lot of people working right now as we talk about the future, really, really hard across our healthcare system and across society. And I had to just pause as we get excited about what's around the corner to remember how hard it's been for a lot of people in the last 90 days and how much grieving there is in different ways for what we've been through and for the loss of life that's happened. And I don't mean to start on a downer note on a panel that's all excited about the future, but when I hear the code blues going off behind me in my hospital, and I know what that means, a protected code blue, or as I work with our long-term care homes where so much life has been lost, I just had to pause there. I'm going to talk about primary care, and then I'll talk about hospitals. Two things. First of all, you'll notice, one thing, you'll notice there's a bit of overlap here. These are not distinct conversations. This is not a conversation about primary care and what primary care is going to go through, and hospitals and what hospitals are going to go through. And I might touch on long-term care, and that's not going to be like a whole different, you know, bailiwick or whatever for long-term care. That actually the drivers that are sort of shaping and molding the healthcare system are actually sort of unifying and are actually more shared forces of change than they are distinct forces of change. And I actually think that's an opportunity, because if all of us had to change, but in very different ways, according to very different drivers, that's actually really hard to do. But if we're all being molded by similar forces of change, that's actually like an opportunity, and it's a good thing. So let's talk a little bit about primary care. You know, first of all, one of the real challenges is around PPE. When you look at ethical frameworks developed by governments and systems, you know, community and particularly primary care have not been particularly high. In some ways that's good. We haven't seen some of the, so primary care has had to really, really change. But as we want to move forward on primary care, we're going to have to start really thinking about how do we allow primary care to safely open and really pay attention to physical structures, to PPE, et cetera. Primary care, a lot of it is still quite small and localized, and we have to think about that. The second thing is virtual care. I mean, I'm a family doctor. I still do a very small amount of practice. It's all been virtual. It's been a profound transformation. There's small exceptions. I found it very hard to put an IUD in virtually. We had a long chat with the woman, and you know, we had to do that face to face. But a lot of this is pivoted virtually, and how do we continue that? How do we make it logical? How do we think about compensation? How do we think about technology? You know, I just got off a phone call right before this with somebody saying, oh, you got to get them on OTN, you're going to use Zoom. And actually this elderly patient who's at end of life, they only want to use a phone, period. And I have patients with mental health and they just want to, they have a landline, that's what they're going to use. And so we just have to realize, as we talk about virtual doesn't necessarily mean Zoom or some of these other platforms. We still have to be willing to go face, we have to find ways of working through this in really profound ways. I think we need to think a lot about integration, and this is just a common theme. If we already were talking about integration before, this is just driven it home in spades. And we really need to, nobody's an island anymore. If we ever thought we were an island, nobody's an island, and primary care needs to really be integrated in. There was a great piece by the president of the Ontario College of Family Physicians saying, we're trying to build a system and primary care in all models needs to be part of it. And I agree with that. And we really, to allow that to happen, we're going to need to take a look at funding structures, compensation structures, team-based structures, et cetera, in ways that we've started. But to Zaina's point, we have to accelerate. We really, really have to accelerate trends that we've been on that actually in primary care, we may have paused, and we need to continue to accelerate that. And then my final comment, I think, on primary care is, Vivek, I think, put out a really nice slide of all those sequelae around immunizations and cancer screening and obesity and poor exercise and mental health. Well, guess where most of that hits first? It hits primary care. I'm not saying it hits primary care alone, and if we wait too long, it goes into emerge, and I get the downstream and upstream. We all have a part, but a lot of those, what I call second curves or echo curves, that are now hitting us, homelessness, domestic violence, all of those things were on Vivek's slide or that I've talked about as second curves. A lot of those fall onto primary care as the foundation of our healthcare system. And so how are we really going to prepare and support primary care to deal with these additional curves that are really quickly coming at us? And that is that, we've got a fantastic primary care system in Canada. We do have still too many people without primary care, so how do we get them connected? And then recognizing that it is our foundational part of our healthcare system that are going to have that responsibility for those things on that slide. Not only, but disproportionately, how do we get them ready? So that's a few thoughts on primary care. I'll pivot to hospitals. Again, it's all about integration. I'm a hospital CEO. I've never spent so much time talking to long-term care homes. I'm a hospital CEO. I spent my morning today talking to home care and our community supports and our primary care teams. And so, again, I think we've accelerated the conversation that a hospital can no longer be four walls looking within. A hospital has to be connected to its broader community in really profound and deep ways. We've got to figure out how to really take these steps forward. People who know me know I'm a huge champion of Ontario health teams. I think it's moving us in that direction. And to be clear, I'm not saying hospitals have to lead. I'm not saying hospitals have to lead this integration. I'm saying hospitals have to be part of this integration. And we often have a lot of opportunity because of the infrastructures we have and the expertise we have to make valuable contributions, which again is not necessarily leading or leading alone. One of the things that's just been profound for me is the data that's come pouring in. I can tell you the dashboards that we've built here in 90 days, provincially, locally, and not just for the hospital. Like I have a line of sight down to the zip code or the postal code that is just unprecedented. I have a line of sight into where every bed is, where every drug is, where every mask is, where every glove is, where every Lysol wipe is. That is just remarkable. And it's allowing us to do some very powerful things to improve patient care. And so I think we need to, and this isn't just my hospital, I think, this is our system in general has become much more data-driven, which is a tremendous tool for innovation and a tremendous tool for research and a tremendous tool for doing other things. I think another area, and Zaina, I think you thoughtfully said, one of our greatest shames is we've stepped back on patient and family care. I actually put out a piece in Hospital News that just happened to be published an hour ago today, talking about this issue. I think we should see this not as a moment of stepping back, but reimagining it. Because even when we loosen up, as Kingston, I saw on Twitter today, is slowly loosening their things, we're not going to have patients rushing to come back here or feeling able or safe to come back. Not because the hospital's unsafe, but because they have to get on subways and streetcars and buses and do other things that they may not want to come in. To be with family members. And so some of it, we have to have a new conversation about patient and family care. I think a lot of amazing innovations have been done around using virtual and digital, but we have to continue that trajectory and reimagine it in context of what, as Vivek said, is going to be an ongoing challenge. I have families all the time saying, can I come in this week? How about this week? I don't think we're going back to 12 people at the bedside or 9 people in the labor and delivery room, or 10 people for every, surgery that happens, 10 people coming in to support them anytime soon. Will we improve and nuance a bit? I hope so. I think so. But we're going to really have to imagine those things, because families and visitors play such critical roles in our system, and particularly in our hospitals, but not just in our hospitals, ambulatory and inpatient. And so we're really going to have to pay attention to that in a large way. Payment, again, just as it's a big deal for primary care, we've had a piecemeal, volume-driven approach to funding, and we've actually, if there's one thing we've accelerated in healthcare, it's that approach to funding. Well, let me tell you, everything's getting slower. Everything's getting slower. And so efficiency is not what it was. Any of you who've ever had a broken bone and have had to go to fracture clinic know what a physical lookout of a fracture clinic is and how that flows. Anybody who's sat in an emergency room knows what that looks like. We just need to really rethink the physical plant, the funding models, etc. The other thing that I think, again, has been accelerated is, we've had a lot of wonderful things said about the front line, and not just in hospitals. They've been called heroes, and rightly so, just like the people who serve my groceries at the grocery store. They do remarkable things every day. But we knew before this happened that there was we use the word an epidemic, that's in the literature, of mental health and burnout. And if we think the last 90 days have made that better, it hasn't. And I think we have to be mindful of the tremendous mental health challenges that are going to affect the front lines. And really, what I would say is I've been really pleased by the open discussion. I've been really pleased by the federal and provincial funding. I've been really pleased to see the tremendous resources invested in mental health. Those can't go away. And we have to continue to create safe spaces and destigmatize places to talk about the mental health of our front line, who already were going through a lot, and this is only exacerbated, and we need to be there for them as this goes forward. I think a lot has been written about choosing wisely. Again, part of the challenge we have is, we've talked about choosing wisely for a long time and doing unnecessary things. A lot of things that should have been happening have not. Vivek has articulated that. But some of the things that shouldn't have been happening have also stopped, along with the things we wanted. And let's not just, in our rush to get rushed to some of the things that we've talked about as being inappropriate, not evidence-based, harmful even. And we've got a literature base to do it. We've never had a moment in time to clear the slate and put those choosing wisely filters in. And so let's use this as an opportunity to do that. I think the other thing is, people who know me know I used to spend a lot of time at Health Quality Ontario and QI. One thing, all those great things that Zaina pointed out, 10 days of tremendous change. Well, none of those have been perfect the first time. And we've really had to take a QI, PDSA, rapid cycle. Oh, that's not quite right. Oh, iPads don't quite work. Oh, that's not quite right, et cetera, et cetera. How do we actually take what has become not just an innovation lens, but a learning lens? Like, we have really become rapid learners. We've talked about a learning health system. Well, we've done that incredibly fast. And we want to continue that with that QI, quality improvement learning lens. So here's the final point I'll end on, and there's 2 points. One thing that we don't talk enough about, and Vivek highlighted it, is this virus has not affected us all equally. the social determinants of health, which have driven inequity and disproportionate or inequitable health outcomes, have only been exacerbated by this. And we need, as we redesign those systems, to really think about how they help people. And I love the list that Zaina put out, but if I think about how well do those work for the type of people who are on this panel, and many of the people who are on Twitter, how do those types of innovations, the banking and all that work for well-resourced, well-educated, English-speaking, middle to high income, versus how do they work for the types of people I see in my clinic in downtown? I'm not sure that we've innovated for everyone. I think we've innovated sometimes, as we always have, for the people it is easiest to innovate for. And the second thing is we can't take for guarantee the trajectory that Zaina has outlined for us. There's going to be tremendous pressure to regress towards the mean, to snap back to the past. And the pressure is going to come for a number of reasons. It's going to come because the money that has driven some of this innovation may not continue. It's going to come because the burnout that comes with rapid innovation is going to start to set in. It's going to come because we'll be told that we have to solve our backlog really fast. And when you want to move fast, you go to things you know. And so we will want to go back to what we've done because we're being told we have to get the backlog out of the way. And innovation still takes some time in the PDSAs. And so there'll be a lot of countervailing pressures against Zaina's excellent, excellent vision that I support. And so we'll have to figure out how do we take out the barriers to the natural barriers, the natural regression towards the mean, the burnout and everything to achieve Zaina's influence. Because we can't assume we're now on a downhill slope toward what Zaina is outlining for us. There's still an uphill battle, and actually there'll be more barriers to achieving her vision, which I support, but we got to remove those barriers and support people in getting it. Thank you so much.
Thank you, Joshua. So we have a good half hour left, more or less, for discussion and questions. We've had a lot of interesting thoughts, some conflicting thoughts, some challenging thoughts, both of which I think lead to the potential for a really interesting discussion. I want to start off with a recognition that all three speakers, not surprisingly, highlighted the need for change, recognizing the fact that our system is somewhat out of date. And Vivek spoke about the Constitution being the greatest challenge to the health of Canadians, or the Canadian healthcare system. If we accept that premise, how do we address the issue of the challenge to a universally funded healthcare system and the challenge of private care that has raised its head prior to COVID in some areas, but has become more prominent during the COVID period. So I don't know who wants to jump in first to address that, but I would like each of you to respond to that challenge to change, to the significant change that we're calling for in our healthcare system.
Maybe since I had that point, I'll start off and just say again, there I'm talking about particularly as challenges to the population health and public health, and the division of powers, right? The powers for quarantine are federal, other powers for healthcare are provincial, and so coordinating, and we saw it, for example, when they're trying to sort out how you do screening at airports. Is it the federal government? Is it the provinces? Is it the local public health authorities? And we had all sorts of different things happening across the country. So, how we coordinate some of those functions that are critical to health and population health is what I was getting at there. But I think your point is actually much deeper. We talk about a Canadian healthcare system, and I think probably everyone that's a member of CASPER knows that there is no such thing. First of all, there's no system, and there's not a single one of whatever we do have. But we aspire to having some standards and coordination. And so again, I think to have the Premier of Ontario saying, I'd like to have a federal solution to contact tracing that I could buy into. Like, I think as everyone's in normal times, we'd never see things like that. And whether we need a national solution to contact tracing or not is a different issue. But the level of conversation has changed. And so maybe there is going to be an opportunity to try to coordinate on some of these things that we need to have developed. And that's why I use the example of CIHI, and it's a base to work from in terms of an organization that operates in the federal, provincial, territorial space. So I do think on a number of these fronts, and information is obviously a big one. The private sector, I think, is another thing that we really have to think about. First of all, we've always had private health services in this country. And let's not, physicians are private operators, and pharmacies are private, and dentists are private, and hospitals are private institutions, right? They're not for profit, but they're private institutions. So I think we have to get that sort of out of our mindset. In fact, if anything, we have to think about how do we bring organizations together. But in terms of private financing of health services, and again, what's happening in long-term care, and we've got lots of debates about the role of the private providers and so on. We have to examine that. But I'll just flag one thing that I see coming very immediately, and that is going to be on testing. We have banks talking about setting up their own labs to test their employees. And that's just making, Zaina had the point about BMO hiring a whiz kid, 28-year-old physician, who's essentially going to be helping them design that, right? And we're going to have people wanting to get tested in order to go to sports events, right? We're talking about things like that at some point, if immunity is possible and so on. So we're going to have a major entry point for privatization. And I think the inequities will even increase further, because we'll have some people that will be getting access to a set of services coming out of this that not everyone else is going to be able to afford. So I think that's something that we will have to pay attention to.
I'll just build on that with 2 points. It's funny on the testing, like I really want Ontario to get their numbers up. So I put all over my Facebook to my family and friends, like, here's the link, go get tested. And right away they all piled on. They're like, I'm never going to go to a hospital to get tested. I don't want to get sick. And I'm like, what? It's at hospital? Like, I didn't even think that was the only thing. And I know that's not across Ontario, but in the city where I'm from, there's only one option, and it's going to a hospital. So I think, the private sector will be bringing solutions that are going to create a very different experience than what the public sector can do. I am not a fan of having this private healthcare debate anymore. I think structure is structure. Everyone is good and everyone is bad in every comparison. There are pockets of amazing excellence, no matter what the structure and the governance is, no matter what the corporate entity is. It's finding those positive deviants, and I think a lot of what Josh does every day in his job is one of them. And training people to think different, be different, behave different, and create the health system we want. And I think structure will never be good enough, but some really, really smart policy and legal instruments, like one of them could open up a lot of opportunity, like changing the Canada Health Act, which has come up a lot.
I'm good. I think there's been 2 good answers, and conscious of getting a few more questions in, Alan.
Okay, thank you. So another area that there were a number of questions on the list was around the role of patients and public in this transformation that we're talking about that's needed in our system. Specifically, there were questions for Joshua about the way hospitals could do that, but I think it's a broader question. If we are going to be changing, how do we actively engage the public and patients to be involved in this in a meaningful way?
Yeah, I mean, I think it's a no-brainer. I think it has to happen. I think it will happen. And actually, I think it is happening. Like when we created our visitor policy, we actually involved our patient and family advisors. We have our weekly Ontario Health Team meetings, and we talk all about what we're going to do across our local North York health system, and we have patients who participate in those. So I think it's happening. I think it will continue to happen. Just like everything else, will it have to happen a bit differently? Yes. Have we totally figured out in all cases how to make it happen differently? Not yet. But my I could be wrong, but I sort of feel like that is a well enough entrenched concept, at least in much of our system, that we will be able to do it. And it's continued. It just has, like everything else, it's become slower and less efficient. And so we just have to be mindful to bring it back. But I feel of the many things that I worry about recovering or accelerating, fortunately, that's a little bit lower. I think the pre-existing deficits of PFAC, or patient family engagement, around equitable engagement, having breadth and diversity in that remains as a pre-existing challenge that we need to continue to lean into. But I think their voices have to be very much part of it. And I think there's been some very good social media, lay media, inside, outside government policy examples of it, and we just have to continue.
The other two want to jump in on that one? Nope. So there was a question for Zainab about as we move forward towards a gig economy, what threats do you see in addition to opportunities? How can we more clearly bring the health implications of non-secure employment, etc., into the conversation and future-proof these aspects?
Yeah, I'm seeing some comments. I hope you guys don't think Zaina's the rosiest person in the world who sees positive, because I'm actually the opposite most days. I get very frustrated with what I see. I was just framing something for us to think bigger. So let's be clear, it's not all silver linings. And I think Vivek's slide of the consequences is spot on. And so all of us are designing and managing with that in context. And much like Josh, I mean, we see 20,000 Canadians a day in their homes. The majority are, median income, fixed income, everyday hard stock kind of Canadians. And that's who we are designing for in our work. So all these implications of unemployment, housing, access to care, isolation, language disabilities are all part of how we're thinking about the future. So those are all implications. I agree.
Alan, if I could just maybe make a broader comment, because I see some concerns being raised about the discussion around private and for-profit. And I just want to be clear that I'm not advocating for private or for-profit. And I think Zaina and the others are saying the same thing. We're just pointing out that this is happening. And some of those trends are going to get accelerated because of the failure of our public systems. And again, not pointing the blame, because it's a system issue, it's a political issue, to be able to adapt over time. There was an example reference to Maple and the banks moving in with their own testing. If we're not able to deliver, that's going to happen. And the people that can afford to pay for it will continue to gravitate to those services. And so, I think it really behooves us to think about, why is it happening? Like, you can't just say we got to stop privatization or for-profit people. We have to say, why haven't we been able to address the needs that patients and families are looking for? And so some of them at least are starting to look to these private sources.
So I want to go back to the point that Vivek, that actually you made around, it's about a governance issue when you talk about the Canada Health Act, and the fact that we don't have a single system and the federal-provincial relationships. There's a question that talks about, that brings it a little more practical. What are recent suggestions how to effectively create a trans-provincial territorial with federal involvement, coordination in healthcare? We've had lots of good discussion around what needs to happen. I'm not sure we've gotten down to how to make it happen.
So, I'll start again. I think if we, first of all, think about the difference between federal and national, right? So the federal government is the government of Canada, has a set of powers under the Constitution Act, and then there's provincial and territorial governments as well as municipal governments, but the municipal governments are creatures of provincial governments. National brings the FPT partners together, right? And so, first of all, we need to get consensus around, if we're going to set standards for healthcare, It's not standards set by the federal government that the provinces have to follow. There's got to be mechanisms whereby we create consensus with the provinces and territories around the standards that as part of the process, everyone agrees to follow in their delivery. And so like that's something that could be done and is done in quite a few areas already, but it could be done more without having to touch the Constitution itself. The other place, the other mechanism, which I think is sometimes seen as a more coercive, is the use of the federal funding powers, the federal government. And I think, again, one thing that's coming out of this, the provinces are going to be broke by and large, and the federal government will have a lot of financial levers. And so that's traditionally been the way in which the federal government has used its powers to drive change in health in particular, by putting money on the table and then getting provinces to follow suit. I think what I would say, there's people on this that are much more familiar with the research around this, but the provinces have begrudgingly taken the money and tried to do the minimum they have without ever actually trying to work towards the coordination that's necessary in those federally financed schemes.
So I know a lot about a few things, but this one I don't know a lot about. But I will say what I see with just new ways to work with different people is my view is always bottom up. Just get on with it and do something interesting and a little bit dangerous federally with whatever jurisdiction, and prove that it works and see something and then build up from there instead of always trying to solve everything top down.
Yeah, I don't think I have much to add, except that I would say that, this has been a global pandemic. This has certainly been a national pandemic. Not every country, not every city has been affected equally by any means. But there has been a commonality of experience, of learnings, and I think we shouldn't be too quick to sacrifice that. Just as I talked a lot about how the healthcare system has sort of worked together in unprecedented ways, I think country and countries have had to work together in unprecedented ways and on very hard things like border crossings and stuff. And I'd hate to see that be totally squandered as we regress towards the mean or we snap back. I think there's been innovations in policy and relationships that are important.
So we haven't spoken a lot about care of the elderly, in particular the disaster that personal care homes or long-term care has been in Quebec and Ontario in particular. And I think that we should at least explore a little bit about what next steps exist. We heard that another national investigation or some sort of task force is not the answer. Do we know the answers? What examples internationally should we be following?
If only we had somebody here from home care who thought a lot about care. They were like, oh, wait, I think we do.
I mean, look, we've been, designing those future solutions and not just learning from other countries. There's a lot of great examples here in Canada. This morning on the CBC, because they were exposing the thing yet again with Quebec and Ontario, everybody kept mentioning British Columbia. And then, on the chat yesterday, a destination home model from Alberta was referenced. So again, there are thousands of experiments. Everybody kind of knows what to do, and you can kind of do it within the funding structures. But to undo the inertia of the existing thing that is just a lot easier to keep, that's the hard problem. It's not knowing what to do or how. So I'm hoping with this, because there's such a spotlight, and I'm kind of seeing it a little bit, much like all the rule books were thrown away to allow us to just get on with it for the crisis. I think some of those rule books are going to get thrown away to just let people have some space to do the right things with the partners that they have. And there's some examples. I know, Josh, you can probably talk about what you're doing. We're collecting great examples of new models of elderly care that are springing up overnight and getting funded.
I'll just point out an irony here is if we go back 30, 40 years, before Ontario started its perpetual restructuring of home care, home care was run by public health in Ontario. And the medical officers of health in many parts of the province had responsibility for home care and for the municipal long-term care facilities. And we actually had integrated systems that tried to keep people healthy in their homes and only move them into the facilities. And so there's lessons to be learned from the past here as well. And there's all the technologies and all the other things to think about that I know Zaina's talked about. There's lots of lessons from other countries, and I know I've heard Zaina talk about that in other settings, but we also have to look to our own lessons from the past.
I mean, I guess I would just say I agree with all that's been said. I'll pick up on just a nuance of Zaina's comment. There's no doubt that the statistics are sobering, and some of these stories are really, really hard and gut-wrenching. But as our premier said yesterday, there's over 600, I think over 640 long-term care homes. And we want to be careful about using a broad brush. And as Zaina said, there's examples of excellence, and there's examples of innovation, and there's examples of compassionate care and innovative care in all parts of our system, including long-term care. I think we just, we've heard about some devastating examples and homes, but there's many places that if we went in, we'd have tremendous pride in, and a tremendous sense of celebration of how those people are being cared for. So I think, again, it's just all about, turning towards, I think, positive deviance, as Zaina said, and figuring out how did they do it? How did they work around, how did they take the same environment that everybody else was given, the same funding models, the same regulatory framework, the same regulated, unregulated health professionals, the same sort of buildings, and do something very different? And what can we learn? And some of that's global, and some of that's in our own backyard, which is wonderful.
So I'm struck by some of the comments and questions that came from patient partners in this session. And it's really very heartening to see the number of patient partners who are participating. And it's something that Casper has been trying to achieve. Fortunately, the virtual environment makes that somewhat easier. But I'm wondering how we who are part of the system can better facilitate that engagement and help those patient partners and become, their voices be better heard to bring about these kinds of changes.
So Alan, I think that's a really important point. And, a lot of the things that we're talking about that have, been inertia for many years is a result of political inertia, or sometimes the fact that the focus of our government shifts over time. And, I appreciate all the comments at this, Zaina's reference at this moment for public health, but I've been through SARS, I've been through H1N1. 6 months, a year from now, we'll be back. Public health will be back on the list of things to be cut, and it's the same on all these things. There's always a moment where there's a focus, and then the priorities of government. There's a 9/11 or whatever the part. So I think the patient and family community, I think by having them come in and seeing what these issues really are for healthcare system reform, because from the outside, it looks like, why can't we have an app that gives us our immunization history? And then you start to figure out how many systems, or, this Zaina referred to, why does Toronto Public Health get lab results by fax and phone? Now, it's not the public health information systems, right? It's because everyone's got information systems. They're just not talking to each other, the primary care systems and the lab systems, and so you wind up in this emergency still using it. So people have to understand it's a lack of investment. There's been a political unwillingness to actually say, here's the system we're going to go with. And we're not going to drive that change just from within the healthcare system. It's going to require political will. And I think with having the patient family partners at the table in the decision processes, whether it's the hospitals or home care or long-term care facilities or public health, then they'll have a better message when the politicians are coming knocking on their door about what they need to fix.
I think we also have to ask them. Like, I think, that's, we have to create the space, but we have to ask them what works, what doesn't. Like, we're all figuring out a new environment, and I believe, patients and families will have very thoughtful comments and insights into what they think the new patient-family engagement needs to look like. And so I think we just need to really listen and figure out, they are the patients and families, they are the caregivers. What is it, as they see this rapidly changing world, that they think it needs to look like in the co-design?
So I think that's a good point to end on, that we do need to ask them. I think we who are working in the healthcare system, we're there to serve our patients. So asking them is the right way to go. But I also, as a closing comment, unless somebody wants to respond, want to suggest that those of us who are part of the system often have privilege. And we need to use that privilege to empower our patients within the system. So we need to ask them, and we need to represent them better to power, to politicians, to other ways to have that message move forward. So I'm not seeing anybody wanting to jump in and challenge.
Can I just make one minor thing on there? I think rather than talking about patients, I think we should be thinking about citizens.
Yeah.
And the conversation, again, as I said, has to be about how do we keep people healthy and provide the services when they're ill. But again, politicians will say, they get asked questions at the door about, can I get service or this healthcare service for my grandmother? Politicians should be getting asked, how do I keep my grandmother at home in a healthy way and not need to have a health service? And so and if we focus on patients, we're always focusing on when the illness has already taken place. So I think we have to think about it from a much broader perspective. It's the conversation.
I would say it's a both.
Yeah.
It's not an either or, it's very much a both.
Yeah.
And I'll just add, I bet my career on that. That's the journey we're on, to reinvent our organization around keeping aging adults healthy at home, not around delivering care. Just the last point I want to make is, I think in healthcare, just like firefighters, like, we love the crisis. We'll come in, we'll do workarounds. That's all we do, is we hack our way through things. And we're really good at it, and we've shown it. And I think like the new muscle we got to develop is that the creativity, the patience, the discipline to design like real systems and management that help us absorb all the shocks that Vivek just showed us are coming, because we cannot do it in a firefighting way. It won't work. So that's kind of just the one thing that I want to leave us with.
Thank you. So I just want to end by thanking our speakers in particular. Appreciate the thought and effort that went into this. Some really, really outstanding presentations that have provided with significant conversation and questions on the chat, and questions that indicate how well received it was. So thank you very much to all three of you. I want to recognize those who were involved in the organization of this, Sally Telford and her team at Face to Face, and Maggie Karastici, who is our new CEO at Casper, that we're very excited to work with. I want to thank all of those of you who participated and were present for this virtual Casper session, and remind you that those of you who are not members, please think about joining Casper, and please come back later today for the 2 last sessions that are part of this virtually Casper. Thanks very much, everyone.
Thank you.